I guess you all know I'm Jo Gibson. I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK and a consultant in private practice. And essentially, this is an excuse to share some interesting case studies, get you racking your brains and kind of just sharing some interesting cases that, to be honest, many of them are very rare in my practice, even though I'm treating shoulders all the time. And it's kind of good to share them just to increase awareness. But there's a couple of things I want to talk to you about tonight. The first is about this interesting case study. And the second is just a little bit about what to do if somebody comes to you with shoulder pain after they've had a vaccine, which seems to be very topical at the moment and is causing all sorts of interesting discussion on Facebook and social media. So back to our case, let's try again. So the case is a 50-year-old guy who presented to the primary care clinic with left shoulder pain. He'd had a telephone conversation with his GP, hadn't been seen, reported just an insidious onset of left shoulder pain, and the GP had basically sent him for some physiotherapy. It sounded like it had been quite a brief consultation. The guy tells me that he'd had a fall onto his coccyx when he was out drinking with his mates between lockdowns about 6 months ago, fell onto his coccyx, horrid pain, no history of shoulder pain or any issues with his shoulder at the time of that fall. And had been taking non-steroidals ever since for his back pain, which wasn't really helping. He'd been given some physiotherapy advice. He said he wasn't very good at doing the exercises. But also this guy, as I also mentioned in my first attempt, is very office-based. He's been having to work at home during COVID, and he has a performance based job, so essentially the amount that he gets a basic pay, but basically a lot of what he earns is based on what he sells, and because of COVID and everything else, he's really struggling to meet his targets, and that's causing him a lot of stress. He says during the kind of consultation that he's been drinking more, he's not eating as healthily, he's not doing any exercise, and it's all a little bit overwhelming, and he's clearly having a little bit of a tough time. Anyway, in terms of this left shoulder pain, he tells me that he's got this throbbing deep ache, and when I ask him to tell me where it is, he essentially locates it to the superior angle of his scapula, into the suprascapular fossa, and also into his upper fibers of trapezius. Now, when I ask him about activities that increase his pain, he kind of struggles really to identify anything very mechanical. He kind of says sometimes if he's really reaching up into a cupboard, he can get a sensation of discomfort, but essentially he's kind of got a background ache there all the time. Now, he also tells me that it can be worse at night, and actually after going to bed, after a couple of hours, he's woken up and he really struggles to get comfortable. Doesn't seem to matter if he supports the arm or not. Now, the other thing, as I said, he mentioned about taking the non-steroidals. He's not taking any other medications at the moment. In terms of his general health, he's not got any weight loss. He's not got any signs of fever. He's not telling me any other kind of major systemic signs, apart from the fact he says that he is getting some kind of bloating, and he thinks it's just irritable bowel because he's stressed and stuff. He's got no shortness of breath, he's got no chest pain, etc., etc. Now, again, I obviously want to investigate this guy because at the moment I've got a history where I've got an insidious onset. I've got that previous history of a fall, but no relation to the shoulder. He's not able to give me any very clear mechanical aggravating and easing factors for his shoulder pain, and it's worse at night, which is interesting. So I then ask him some other questions. Now, if you've joined us before and we've talked about gallbladder and endometriosis and some visceral causes of pain, obviously there's some of the questions I need to ask with a lack of a clear mechanical pattern. So I say to this guy, do you have any issues with bladder or bowel function? And he says no. And I said, have you noticed any relationship in terms of eating and stuff? And he said, well, funnily enough, sometimes if I have something to eat, it actually makes the pain a little bit better for a while. And I say, oh, well, do you have any stomach pain? And he says, well, yes, I do actually get some left upper quadrant pain. It's not very bad. It's just a bit of an ache. And again, don't tend to get that associated with meals, tend to get it 2 or 3 hours afterwards. So I've got this guy who's now telling me he's got some tummy pain, he's got some left shoulder pain, can't give me any mechanical features. And so I'm then trying to work out a little bit more about what might be happening. Now, I gave you some real clues when I gave you this guy's background history, okay, because what am I thinking? So somebody with left-sided shoulder pain, Again, with any kind of stomach involvement, and certainly when there's any relationship to eating, there's a couple of things that I want to be thinking about. And the most obvious is actually thinking about gastric ulcer. Now, with this guy, because he basically told me he'd been drinking more, he'd been taking non-steroidals for a prolonged period of time, and when I asked him a little bit more, he was taking the maximum dose. He also told me if he took them on an empty stomach, he actually felt a lot more bilious and stuff. But also, what's the significance of the fact when he eats, his pain gets worse? Well, interestingly, if you look at the evidence about peptic ulcers, so obviously you have stomach ulcers, your gastric ulcers actually in the stomach lining, but you also have duodenal ulcers, which obviously in the upper part of your small intestine. And some studies suggest that if it's a duodenal ulcer, often it will be better immediately after eating, purely because it closes the sphincter while you're digesting your food, and so you've kind of got a barrier to those stomach acids. But obviously after eating, when you've nothing in your stomach and you've stopped digesting, then it gets really sore again. And again, it's very typical that it's worse at night. Now, that doesn't mean that in all gastric ulcers you'll feel worse immediately after eating. And again, there is some overlap and you can have both. But again, this guy, if you look at the kind of risk factors for gastric ulcers, then generally it's an older population above 70 with a previous history of ulcers, but also patients who are in the first few months of taking non-steroidals if they haven't taken them a lot before. And again, when you drill down to the detail in terms of case studies, actually been in the kind of fifth and sixth decades also is a risk factor. So to me, obviously, I'm going to do my objective assessment because that's a really important part of my decision making. And with this guy, essentially, he had full range of movement. He wasn't able to reproduce any end range pain during the assessment. But again, when you think a lot of our referral when the stomach's involved is because of the irritation of the diaphragm, it makes sense that anything that puts stress on that could potentially cause some local symptoms. However, I did his range of movement, I looked at his resisted testing, I looked at palpation, I looked at the area that was sore, and it was very poorly localized and no palpation reproduced any local pain. As I say, so for me, immediately with this gentleman, there are things that don't fit with a musculoskeletal cause. And so that constant background pain, that fact that it's worse at night, the fact that there's a relationship to meal times, the fact that he's been drinking loads of alcohol, taking non-steroidals, and he's got some left upper quadrant pain, then it's important he gets investigated. And as it turned out, this guy did have a gastric ulcer, and actually just stopping taking the non-steroidals and modifying some of his lifestyle stuff actually got rid of his shoulder pain completely. So I was completely redundant in this case. But I just thought it was a really good one to flag up. If you've joined us before when we've talked about gallbladder, endometriosis, all those different things, there's some very common themes in terms of a lack of a clear mechanical pattern, a lack of a clear cause, the fact that, relating to some of those other major organ functions. So if we thought of cardiac, obviously we'd think about sorry, I'm trying not to get distracted by the comments, just checking that I'm still online. If you look at things, obviously cardiac related to exertion, if you look at anything stomach-wise related to eating, obviously asking about bladder and bowel, because somebody with a more severe gastric ulcer could give you more descriptors in terms of dyspepsia and problems with indigestion. They can have nausea and vomiting. This guy just felt bilious for a while after he'd eaten and often felt full, but didn't have any more severe signs. But interestingly, if you go onto Google and you type in visceral referral to the shoulder, often it will just show you pain between the shoulder blades, so in the mid-thorax region. And again, that can be an area of referral. But interestingly, there are case studies that show a couple of examples of patients who had gastric ulcers who didn't actually have stomach pain. But again, the key thing was that consistent pattern in relation to eating and that pain at night. So again, just one for interest, really. Again, to add to your unusual causes of shoulder pain and add to some of the things that we've described already. Now, one other thing I just want to talk about this evening before I leave you, because it's been all over social media this week, is SERVA. What is SERVA? If you've not heard of it, it's shoulder injury related to vaccine administration, and it's causing all sorts of excitement because obviously lots of people are getting vaccinated at the moment. So is it something that we need to be aware of? If you look at studies of SERVA, its nice acronym, then essentially there was a study that looked at over 400 patients, and this was after a flu vaccine, and essentially showed some very common themes. 83% of the cohort were female. The mean age was 52, but the age range was quite large, 18 to 94. The average BMI was kind of within normal limits, so that maybe slightly to the upper end, but nothing too exciting then. However, the thing that's really important to say is whilst there are studies looking at patients who have developed shoulder pain after a vaccine, there's been a big study on 12,000 patients. This again was the flu or influenza vaccine. 12,000 patients. So it was a study by Gonzalez et al. And essentially what they did is look at all the patients that had had vaccines, and then they looked at an age-matched control, and they looked at the incidence of shoulder pain in both populations. And suffice to say, there was no difference. So essentially what it was saying is that actually it was coincidental rather than causative in terms of the injection. Now, this is really important research to know about, because for patients, there's so much anxiety around the vaccine at the moment with all the stuff that's going all over social media. It's something that we're all being faced with. But actually, as healthcare practitioners, we're likely to see patients who might develop shoulder pain after a vaccine. And it's really important that we reassure them that actually it's quite normal to be sore for a few days. It can take up to a week to resolve. I actually had bilateral shoulder pain after my vaccine. How bizarre is that? But again, it went after 4 or 5 days. Now, there are a few exceptions, but they are very rare. If you've had your COVID vaccination already, I'm sure you've seen those pictures that are by where you have your vaccine that basically show a triangle, which is 2 to 3 fingers below the acromion. And they also advocate that the person giving the vaccine sits down when they're doing it. And that's based on research of increasing accuracy of where you give the vaccine. The bottom line is true evidence of shoulder pain related to a vaccine, and that's cases of frozen shoulder, but also cases where they've got a humeral periosteal reaction where they've actually hit the bone, and also those that have had bursitis diagnosed. Now, again, we could talk about that for an hour, whether that's valid or not. But essentially, in those groups where they've had prolonged shoulder pain, so 2 to 3 months after the vaccine, then generally it's been associated with injecting too high, injecting into the radial nerve or axillary nerve, obviously in the wrong place, where again they had immediate sharp pain and neuropathic type descriptors. But those patients, again, who had it too high and then developed pain within hours or a couple of days after the injection, again, reassurance is really important. Now, about half of patients, according to the current studies, end up resolving with an injection or physiotherapy. It's very rare that anything else is needed doing. And so again, the key things that we need to think about when we see patients who have shoulder pain after an injection, particularly if we're seeing them early, is reassure them. We know from the lovely Liz at Betts research that essentially psychosocial factors in themselves can be a big cause of developing stiffness and prolonging shoulder pain. So if you like, our job really when we see these patients is to reassure them that generally it's coincidence, and one of the important things is to get patients moving. Again, if you've got pain inhibition, your deltoid probably isn't doing its job quite as well. So maybe moving, but thinking carefully about the exercises we give our patients is important. But the fundamental thing is keep using your arm and reassure our patients it's unlikely to be anything serious. Now, of course, I don't even know what the reported instances of infections are to vaccine, but it's incredibly small. And really the reason I wanted to bring this up is I've had several patients that have come to me after vaccinations with shoulder pain who, because there's so much about it on the internet at the moment, and there's actually a national vaccine compensation program in some countries, that actually it's just increasing people's vigilance about it. And we're so well placed to reassure people and set them on the right track. Now, there is a yellow card process in the UK that if patients do get a nasty reaction, that they can report that. And that's obviously useful in terms of ascertaining some of those effects. But fundamentally, as I say, the most important thing I want you to remember is that Gonzalez study. 12,000 patients having the flu vaccine, and most SERVA incidents have been reported in association with the flu vaccine. We don't have a comprehensive data set about COVID, but I know there's lots of different groups looking at this at the moment, so that no doubt will emerge very soon. But really, I just wanted to share that because, again, as I say, we're often the first person to see these people, and if that reassurance endurance and that keeping going is really important so that we don't scare people, they don't start protecting the shoulder and almost then develop a problem that they didn't need to. So guys, 25 minutes has gone already. I'm very aware that we had a bit of a bumpy start for the first 5 or 10 minutes. And I'm really, really sorry about that. I'm just going to see if I can just open this a little bit more and see if we've got any questions, because I'm going a bit blind. Yep, so as Tim says quite rightly, if they inject too high or they inject too deep, then that's again back to what I was saying about the position of the injection and why you see those pictures on the side. What was the name of the study? Gonzalez, I'll put a link to that on the Facebook page, Angie, just so you can easily access that. In fact, I've actually put a Dropbox thing together of articles about server because it's been causing so much excitement recently. So I will have a look at putting a link to that. I just need to be a bit careful about copyright, but I can certainly put links to the ones that are free access and PubMed links to the ones that I think are really interesting. You're very welcome. What's the name of that study? Yep, so I've done that. Guys, I'm going really blind. Sorry, I need my glasses. You mentioned on Twitter that you had some papers about server. Yes, sure. So guys, if you want a link to the Dropbox, probably the easiest thing to do is DM me on Twitter. If I'm not following you, just let me know and I'll follow you back. But as I say, I'll also put links to all the papers in that Dropbox link on the Facebook page when I finish this evening. Because that Gonzalez study gives you a really nice overview. The one that looks at claims for compensation shows you the typical demographic of people. So again, it's if you see somebody that is in their 50s and female and had horrid pain straight away, or tells you that the injection was high, then you're going to have more of a suspicion they could be at risk of frozen shoulder and therefore a lower threshold maybe to consider injection. So all that information put together is just really helpful in guiding practice. But as I say, the key message is that we want to reassure patients that in the majority of cases, it's coincidence, okay? So yes, I promise I'll put those things there for you. Right, guys. Well, firstly, huge apologies for that very ropey start. I'm delighted and slightly reassured that we could actually get it off the ground, because otherwise I'm not quite sure what I'd do, because I'm probably going to be here for 6 weeks. Next week, we're going to return to some rehab gems. I think it was Marlene last week asked us to talk specifically about subscap. So we're going to have a talk about when we might need to think about subscap specifically rather than just our general shoulder rehab, and importantly, some useful things for you to take away. So guys, as ever, it's been great to join you here. I'll take on board all the comments about how you access those papers. So I promise I'll sort that out somehow. But again, keep an eye on the public page at Clinical Edge and I'll make sure all the links are on there too. So if you're not on Twitter or I'm not following you or whatever else, don't worry, you'll be able to access them. And again, you can also email the Clinical Edge team if you struggle accessing any of the papers, and then we can help you do that too. But there's definitely quite a few of them that are open access. So guys, again, I'm now going. I've been doing a wind up for about 5 minutes and I keep seeing your lovely comments and can't help myself out answering them. But really hope you found that useful. Again, some unusual things, guys. You know, the fact is a 55-year-old coming to you with shoulder pain, it's probably going to be cuff related. But as soon as things don't fit, you just keep that level of vigilance. And so sharing with you some of these unusual causes, particularly visceral stuff, just keeps it in your radar, keeps it in your toolbox. So we just flag up those patients when maybe they need to see somebody else. Thanks for joining. And I'll really look forward to seeing you all again next week, hopefully without any technical hitches. Bye for now.